Welcome to the CQC podcast. We're here today to talk about the State of Care report from CQC for 2019-20, or to give it its full grand title, the State of Healthcare and Adult Social Care in England 2019-20. My name is Nigel Watts and I work in the editorial and planning team in CQC's Engagement Directorate. And we're here to talk to Ian Trenholm, our Chief Executive, about the State of Care report, why it's important, and what some of the main messages are that are coming out this year. So welcome, Ian, and thank you for giving us some of your time today.
Hi, Nigel. It's great to be here.
I thought we'd start just by asking you your initial thoughts on this year's report and why, obviously, this is an unusual year that we've all been in. And I suppose just what your take is for this year's report. What's your main thoughts about the messaging from it?
Sure. I think there's a couple of things. Firstly, it's the sort of, I suppose, the statement to the obvious, which is, this is a year in two halves. There was what was going on before COVID, and then of course there's what's gone on since March. In some respects, the state of care pre-COVID meant that certain services were able to cope with things better than others. I think in a pre-COVID world, I think what we saw was the state of, was that care was generally good, and I think what we saw was that there's been a year-on-year improvement in acute care. In hospitals, what we saw that was up again. Each year we see 2 or 3 percentage points improvement in the number of acute services which are rated as good. What we saw was static ratings, but from a very high base in GPs, social care, and other primary medical services. I think the thing that did worry us, though, was there are some services which have struggled in the past. Emergency care being one of them, maternity and mental health are another couple that have worried us. What we're seeing is some improvements, particularly notably in places like maternity, but not quite at the same pace as other services. So I think that fact that they're not improving as well, and the fact that there are still relatively high numbers of services that requires improvement or less. So that, for example, maternity, 40% of services requires improvement. So, and I think in mental health services, what we're seeing is some of the services for learning disabilities and autism in inpatient settings are struggling in some places, and we've seen a significant increase in the number of services which are inadequate, which is obviously our lowest rating. And in social care, what we're seeing is a fragile sector that has become more fragile in COVID. And I think social care is definitely a read across from a position where we've talked for a number of years now around the need for a long-term sustainable funding solution in social care. And you overlay then the challenges of COVID on that. And I think there's some real challenges, particularly around investments in infrastructure and also workforce planning. So, and then of course in GPs, although the services, although the overall quality of care is good, what we see is that does tend to mask a little bit of turbulence. So about 180 GP services decreased in ratings from good to requires improvement or less, and broadly the same number went back the other way. So, but in real terms, that's about 1.5 million people who are registered with GP practices that saw their care deteriorate below good this year, which is an important number, and it's important that we recognise, I think, the good work that GPs do, but we do need to recognise that there are a sizable number of practices that do need support. So
I suppose there's clearly challenges for providers going forward into the next year, and exacerbated by COVID-19. What do you think is the sort of the main messaging here for people who use services from CQC's perspective? I'm just thinking about, I suppose, some of those things that you talk about when we talk about the quality in terms of ratings. Obviously, we're still inspecting in the same way in many ways, and these are challenging times for us as well, for CQC, in terms of what we do. What messaging do you think is out there for people who use services?
I think there's a number of messages. I think the first one though is that the people that work and also volunteer in health and social care continue to do a fantastic job. We talked about that last year, and we acknowledged that people were doing a really good job. And I think we've just seen that in spades. We've seen that being amplified during the COVID period. In some respects, I think as the regulator, we have the privilege of talking to people in health and social care every day, and the response of those members of staff during COVID has not been a surprise, and that's in no way diminishing what's happened. But we knew there were really fantastic people working in those services before, and they have absolutely risen to the challenge. So I think there's a message to the public that says there's some great people working in health and social care. I think the other message is care is generally good, and yet there are undoubtedly services that have got some challenges, and we write about that in our reports, and we occasionally have to take enforcement action and so forth. But your chance of getting good care when you social care system is really high in this country, and again that's a positive, and that's I think has remained the case during COVID. I think there's what we have seen though is during COVID is the potential for the inequalities to be magnified. What we saw pre-COVID was fault lines starting to spring up for certain groups of people perhaps who came from more deprived backgrounds, people who are disabled, perhaps people from Black and Asian backgrounds. And what we have seen during COVID is that's got worse, because what's happened is there's been this understandable desire to make space in the health and care system for people with COVID, and in doing that, it means that people with perhaps more elective conditions, or perceived to be more elective conditions, have been pushed out of the system, and that was fine for a short period of time at the beginning, but sort of 6 months into COVID now, and as we're speaking, we're about to go into a second wave, with significant parts of the country in the tier 3 lockdown. It cannot be right that if you've got if you're worried about having cancer, or you've got a long-term condition which has been relatively unmanaged for the last few months, that you should continue to do that for another 6 months. That just doesn't feel right. So I think there is an enormous challenge for the health and care system to rise to serve both people with COVID, but also people that haven't got COVID, and make it clear that they're welcome. And I know many services want to do that, but sometimes there's a sense that in talking about the need to be COVID secure and COVID safe, and this sort of language, it does tend to send quite subtle signals that say go away. And so if you're somebody that's worried about a medical condition, you're not feeling 100%, you may not necessarily go to your GP, and you may not necessarily get your referral into hospital and so forth. So I think there is a message here that the NHS is staffed by great people, and it is open for business, and the same goes for social care as
you
well.
You mentioned system, the system there, and I think the last several years now, in individual state of care reports the last few years have talked about increasingly the importance of the local systems, and how they can make a difference for people. I'm just wondering to what extent, how, I suppose, looking forward, how you see us talking more about systems and the difference they can make for people in we're thinking about next year's state of care report. We start now, and what are your thoughts about how we go into that territory and talk more about systems and the importance of good systems for outcomes for people?
I think systems are really important. I think they're important on in a couple of different ways, really. I think, first of which is providers are starting to formally organise themselves into systems. So you get groups of GPs coming together. There's legislation on the table now, which I'm hoping will wash through and create formalised collections of of activity. I think you've got providers who are starting to think about the way they deliver care in quite a different way. So you've got providers who are delivering both acute care and general practice care at the same time. You've got people getting interested in how to make sure that discharge facilities and step down facilities out of hospital into long-term social care is a much more managed activity than it ever was before. And during the COVID pandemic, we did some work on provider collaboration reviews. And again, one of the things that we found there was that those areas that had coped better with COVID were often those areas where there was good relationships between different parts of the health and social care system. But I think actually you need to think about this beyond what we regulate and in the very, very broadest sense. I think those areas which have got a long-standing cohesive community about them, that include food banks, that include volunteering being integral to what's going on, that have relationships between social care, local authorities, the NHS and so forth. Those areas that can glue all that stuff together feel like those areas that are most resilient to deal with this sort of stuff. And I've heard stories even within CQC of colleagues who've got involved in local voluntary groups and have connected, helped connect things together. And there's certain communities seem to be just better at that sort of stuff, and can also make sure that they don't leave people behind. We had some sort of great stories when we were doing the provider collaboration reviews of individuals who were kind of well respected in their community, who were able to bring people together and get the community to lock down early, or to think about things in a different way and do things which you've never thought possible. There's a great example of a really well respected GP in one location who had gone to the mosque on a Thursday and said, look, we think the country's about to lock down on Monday. Things are just getting a bit out of hand. Can we not come together for Friday prayers? And if you'd said that in the normal sense of things, you would be told that that couldn't possibly work. But actually, because he was a well-respected individual and was working on with public health colleagues, it was a conversation which was possible.
I think in that, finally, I think there's when I think about the state of care reports that we've done in recent years and the various messaging that we've put out, and there's often we try our best to be influential and make positive change. I suppose my last question would be about the importance of this report, I suppose. And I know it's so it's a report that we have to do each year by statute. So I'm just wondering if you could describe how you feel about the importance of our state of care report. And I suppose there's the content of the report which is important for all sorts of people in different ways, and of course we're reporting to Parliament. But what would you say is the importance of this report in terms of for providers and for CQC as well, I suppose?
Yes, I mean, I think one of the things that's been a feature of COVID is it has been a global pandemic. It has been the largest thing of its kind certainly in my lifetime, and arguably in the last 100 years. And if you follow the news, what you'll see is everybody living in the moment. And I think as a chief executive of a 3,500 person enterprise, which is what CQC is, I'm as guilty of doing that as the next person, where the issue of the day is what dominates what I do. What state of care I think does is it tries to summarize what's going on in health and social care at the moment. It tries to surface some of those challenging questions and those problems that we as senior leaders need to be looking at in our particular enterprise. So we talk a lot about inequalities in state of care, and I do think there is something about about leaders' inequalities in all forms as they are planning their services over the next few months. And if state of care does nothing else, it just prods people to think, are my services really looking after those people who are non-COVID patients, those people from Black and Asian backgrounds, perhaps those people with long-term disabilities? Am I genuinely open for business? Am I giving those little micro signals to say my service is open for business? They're the sorts of things they're the sorts of questions that state of care asks. And of course, there's that big question around social care, which is, social care desperately needs reform in terms of funding. It needs reform in terms of workforce. We need to get to a position where we are genuinely making social care an attractive place to work. And again, state of care asks those big questions, and that's what I think it's for. It's not to try and pick apart the micro details. It's to ask those big questions, and keep us all honest as senior leaders to say, what are the things we should be thinking about in the next 6 to 12 months. And I think, in terms of where we are at the moment, I don't think any of us can think longer than that. But they are those big questions we need to ask. That's what it's for.
Thank you, Ian. That was great. Thanks again for joining us and sharing your views. You can find our State of Care report on our website, or you can find it linked below in the episode notes for this podcast. Thanks again for listening. There's quite a few exciting things coming up in December, so we will be in touch.